Hello, I am Dr. Samin Afzal Junejo from Afzal Eye Clinic, Hyderabad, Sindh, Pakistan. In this video, I will demonstrate the anterior capsulorrhexis technique with closed chamber without giving any full thickness corneal incision by means of a needle cystotome, and my approach is through surgical limbus 2 millimeters 1 to 2 millimeters behind the anatomical limbus. There is no need of adding the trypan below in order to avoid the corneal staining, endothelial staining, and the sometimes mild postoperative cellular reaction. Clear anterior chamber rhexis is performed in presence of aqueous humor with adequate intraocular pressure, and there is a round rhexis created about 5 to 5.5 millimeters in diameter, and with adequate intraocular pressure I am giving a two-step full thickness corneal incision with 2.7 millimeters diamond keratome, and my approach is through surgical limbus. There is a bleeding at the wound site. That is a good sign for rapid postoperative healing, because the blood vessels and the bleeding will aid in rapid healing. Now two side pores are being created by a diamond blade of 1.4 millimeter in diameter. One side port is at 8 o'clock and the other is at 3 o'clock position. These side ports are very instrumental, quite beneficial, maintaining the intraocular temperature during the release of phacoenergy. Also negate the astigmatism against the rule if it is 1.5 or less than 1.5 diopters, and also the side pores help a lot removing the cortical matter and epinucleus from the vertical sides of the back, 12 o'clock position and 6 o'clock position. OVD dispersive is being injected. Hydrodissection has been done before the injection of OVD dispersive. The nucleus is about grade 2, central sclerotic cataract is there, and now through 2.7 millimeter incision I have started doing the Phacoemulsification, creating a trench in the middle of the nucleus. As the nucleus is soft, quite soft, so I will try to take it out of the bag. It is not coming. There is a bit adhesion in the bag, so I will rotate the nucleus by means of a phaco tip on aspiration mode. I will try to rotate it, mobilize the nucleus in the bag, and very gently I have removed it, taken it out of the bag. And now with the phaco power of only 40%, vacuum 550 and flow rate 40 cc per minute, I will try to remove the nucleus by means of a phaco tip with the help of a side chopper, only on high vacuum of 550. There is no need of applying any phaco energy. Nucleus is out very comfortably without any stress and strain. And now I will inject OVD dispersive for the deepening of the anterior chamber, provide the lubrication and facilitate the aspiration of epinucleus and nucleus. As the nucleus was soft grade 2, the epinucleus is also softer, and I will try to remove it by means of a Simcoe two-way irrigation and aspiration cannula. This instrument is an ideal instrument, a classical instrument for this purpose. I will try to keep the Simcoe irrigation and aspiration cannula at the superficial level, at the level of interpupillary surface. I will not go deeper into the bag, and I will try to avoid the posterior capsular rent. Now I am using the side port for the removal of material from the 12 o'clock and 6 o'clock positions. Again I will inject a little bit of viscoelastic solution, OVD dispersive, and then with the help of a Simcoe irrigation and aspiration cannula, I will very gently try to irrigate and aspirate the remaining epinucleus and the cortex. I will maintain the position of the Simcoe cannula exactly in the middle of the pupil, and I will keep it at the superficial level. I will not go deeper and avoid injuring the posterior capsule. And now the viscoelastic is injected to deepen the bag and deepen the anterior chamber prior to do the IOL implantation. In this case, again, as per routine, I will use the IQ foldable hydrophobic intraocular lens, which is a CE marked and FDA approved lens. Surgical approach is quite instrumental for the rapid healing and no scar formation postoperatively, no astigmatism or induced astigmatism. The lens is being implanted exactly in the back, and now I will rotate slightly. I will rotate the intraocular lens slightly in the back to fix the haptics in a vertical state. The haptics should be fixed at 6 o'clock and 12 o'clock position. That can prevent the trembling of the lens and avoid flickering of the light at night, particularly during driving, and the visual haze, particularly at night during driving. Lens, if it is fixed with the haptics vertically positioned in the bag, will not disturb the vision of the patient. It will get fixed rather than positioning the haptics horizontally at 3 o'clock or 9 o'clock. And at the end of the procedure, I will use the intracameral injection, a cocktail injection of steroid, pilocarpine, and antibiotic. Pupil is getting myosed, and the eye is still in a state of a little bit hypotony, so I will do the corneal stromal hydration of the main incision. and complete the procedure. Thank you very much.